Good evening, good afternoon, good morning, everyone. This is Suhail from Dubai. I'm warmly welcome you all to the 11th chapter of the unique webinar series, MENASO Cerebrovascular Grand Round Webinar, organized by the MENA Stroke Organization. It is endorsed by the World Stroke Organization and the American Stroke Association and supported by Boehringer Ingelheim and Medtronic. It's our pleasure to have this webinar to be conducted today with two unique and senior stroke specialists in their field. It will be an interactive session so that we will have a dedicated question and answer session at the end of the lectures. We encourage all the attendees to pose their questions about the topics in the Q&A box. No further delay, I would like to introduce my co-chairman, Professor Mohammed Al-Zawahma, who's a vascular neurologist and a consultant neurology at King Faisal Specialist Hospital and Research Center. Professor Al-Zawahma did his undergrad and residency program in Saudi Arabia. He's Saudi board certified. He carried multiple fellowship from Canada. For example, he's a clinical stroke. Has a clinical stroke fellowship from Calgary University and neurocritical care fellowship from Ottawa, Ontario. At the same time, he carried a Master of Healthcare Administration and Hospital Management. I would like welcome Dr. Mohammed Al-Zawahma, and you can introduce the first speaker.
Thank you, Suhail, for this introduction. It's my pleasure and honor to introduce Professor Gary Ford. Professor Ford is the Chief Executive of the Oxford Academic Health Science Network, consultant stroke neurologist at Oxford University, and NHS Foundation Trust, and visiting professor of clinical pharmacology at Oxford University. He graduated from Cambridge University and held a clinical pharmacology fellowship at Stanford University. He returned to UK and established a comprehensive stroke service in Newcastle in early 1990. He held the Jacobson Chair of Clinical Pharmacology at Newcastle University from 2007 to 2013. He has been involved in many services, innovation in UK stroke programs, stroke care, in the last 20 years, including developing the first thrombolysis protocol for acute stroke in England. He chaired the emergency response working group of the English stroke strategy. He developed the face arm speech test, which is fast, now used to increase the public and professional awareness of stroke. In 2005, he was appointed director of the National Institute for Health Research Stroke Research Network, and awarded CBE in 2013, a New Year Honors List of Service to Research in Stroke Medicine. Dr. Prof. Ford will speak today about acute ischemic stroke, the older patient with extensive medical history. What to do? The microphone is yours, Dr. Ford.
Thanks very much, Dr. Mohammed, and thank you for inviting me to this meeting. I will just share my screen to put up my slide. So this is an increasingly important challenge for stroke neurologists and teams looking after people with acute ischemic stroke. And the characteristics are, we have many more of our patients are presenting with a background of multiple long-term conditions, sometimes called multimorbidity, used to be called comorbidity. They are often taking multiple medications, the challenge of polypharmacy. And they're also, as I will talk a little bit about, frequently frail with pre-stroke disability. And these are all slightly distinct syndromes and features that overlap a lot. So I'm going to just give a bit of background around multiple medical problems in the older population. and then talk a little bit about the issues in managing acute ischemic stroke, with comments on diagnosis, prognosis and outcome, thinking about the benefits and risks of acute reperfusion therapies, management of malignant MCA infarction, and palliative care. So when we think about what we're trying to achieve in the treatment of older people, this is an article back from 1980 by Jim Freese in the New England Journal of Medicine. We talked about the concept of we're trying to delay disability through treating morbidity and rectangularize the mortality curves and maximize healthy lifespan and minimize the amount of time that people spend in a disabled state before they die. And the healthcare system does different things, some of which actually prolong the lives of people when they have disability, but a lot of our focus on prevention and acute treatments is trying to prevent disability and extend healthy life expectancy. So it's worth thinking about some of the treatments we apply in acute ischemic stroke care and what they do to that. So if we think about prevention, when we treat hypertension or we anticoagulate people with atrial fibrillation who are previously well, we're preventing the onset of stroke and disability. And when we give reperfusion therapies to people who are independent before their stroke, who present with a disabling stroke, and those treatments are effective, we are again preventing delaying disability and maximizing healthy life years. But some of our treatments, we know from trials and evidence, actually keep people alive, but prolong the period they're in disability. So if we take hemicraniectomy, it's unusual, particularly if you're an older patient, I'll show you the data, to not be disabled after that procedure. And the interventions to prevent venous thromboembolism tend to work in people with disabling stroke who are going to have longer term disability. And of course, when we offer reperfusion therapies to people who are dependent before their stroke, we're benefiting them, but we are extending the time they potentially are spending in a disabled state. So increasingly, the health system is starting to think about multimorbidity, multiple medical conditions. The definition is not particularly helpful. It reflects, I think, the early stage of clearer thinking and appropriate categorization of multimorbidity. But the simplest definition is 2 or more chronic conditions. And there's a lot of interest in understanding what are the clusters of the disease that occur. Some of those we know very well because they have an underlying etiology, like atherosclerosis. So people with diabetes tend to have chronic kidney disease and stroke and cardiovascular disease in general. But there are multiple measures of comorbidity. I'm not going to go into these in any great detail. And even understanding the extent of multiple morbidity in our populations, we don't have as much data as we need, although as I'll show you, we do have some data relating to acute stroke. And if we look at the sort of measures of comorbidity, I've listed some of them here. The one most people are probably familiar with is the Charlson Index, which is the most commonly used one, or the modified Charlson Index. And whatever you look at, this is a review in the Lancet, as you would expect, the number of disorders people have increases with age. And once you get to over 80, only a small number of people have no long-term conditions when they present to stroke services. This is what the Charlson looks like. It gives different points for different disease measures with metastatic tumors and previously AIDS, although that is doesn't carry anything like the same prognosis now. Of course, we expect people with AIDS to live near normal lifespan, so I think the scoring has changed on that. But that puts different weights on these scales and captures most common diseases, but not necessarily all that are relevant to patients. And it was developed as it's important to say, as a administrative database system to understand burden of disease and case mix and planning of health services. not really for the management of individual patients. This was a study done in Newcastle by my colleagues there when I was there, which looked at, in an 85-year-old population and older, what was the prevalence of common conditions. And you can see here the most common things are problems with hearing and vision, hypertension, ischemic heart disease, osteoarthritis, incontinence, and all of these people will be familiar with and will have seen in older people presenting your stroke service. I think the interesting aspect of this is only 1% of the, less than 1% of this community population, so this was an unselected population, had none of those 20 conditions. And taking the definition of multimorbidity, 92% had multimorbidity and 9% had more than 8 conditions. And slightly more common to see comorbidity in women compared to men. Importantly, the data suggests the prevalence of impairments is increasing in the older population. Partly that's due to the average age of that population increasing, but that will be seen in our services, and we will see a greater proportion of our patients presenting with multimedical problems, which is of course why you've asked me to speak to this topic. And even when you correct for age, we're starting to see that there is a suggestion that multimorbidity in some areas has become more common, such as in the 75 to 84-year-old group. So what about acute stroke? What data do we have on that? Well, this is a large survey from Danish National Hospital Database, and they found that using the Charlson Comorbidity Index I showed you earlier, 43% of patients presenting with first ever acute stroke in Denmark had multimorbidity. The commonest associated problems were atrial fibrillation, cancer, diabetes, heart failure, and chronic pulmonary disease. Another study in almost 30,000 community draining stroke survivors showed that there were high prevalence of concordant cardiovascular disease conditions like hypertension, ischemic heart disease, but quite a lot of other discordant conditions not associated with vascular disease like arthritis and inflammatory bowel disease. And there's a nice review by Peter Rothwell's group recently in International Journal of Stroke, which showed that even in some younger populations, such as rural areas of poorer parts of the US, with younger stroke patients, 20% have multimorbidity. And what about frailty? Well, this goes alongside, but can be seen in the absence of multimorbidity with advanced age. It's been long described in the general literature, such as by Shakespeare, I put a quote there, and it's associated with weakness, slowing, and the sort of picture of the man I showed you on one of my first slides, with weight loss, loss of muscle power, and low energy. There are scales to assess this, and this is distinct from comorbidities I'll show you, such as the Rotwood Frailty Scale. This is a reasonably simple categorization that can be done by nursing staff or other healthcare professionals. But we haven't introduced into most of our stroke services any consistent assessment of comorbidity or frailty. The one aspect we do assess, I think, is disability, because we think a lot about that in terms of planning people's recovery. So I'll just give some perspectives on diagnosis in this population. I'm not done a big literature search for this, just based more on my experience and some of the stuff we published on stroke mimics. So this population frequently has acute illnesses that may mimic stroke, such as sepsis with decompensation of existing neurological deficits, syncope, hyperglycemia if they're on glucose-lowering therapies, and post-ictal deficits associated with unwitnessed seizures. So it is necessary to obtain both a good history of symptoms and, where possible, a witness history, particularly clarifying when they were last well and what their pre-stroke function was and what their pre-stroke drug therapy is. Also, in terms of assessing the patient, be clear what the new neurological deficit is as best one can, and think about that when making decisions using the NIHSS. Some of the NIHSS neurological severity is related to underlying deficits. And although it is not strictly the use of the NIHSS, my decision making is usually around the new elements of the NIHSS in somebody who has pre-existing neurological deficits. It's important to exclude metabolic causes as both a cause and exacerbation of neurological deficits. And of course, CT, angiography and perfusion or MR imaging can be very helpful if the diagnosis is unclear when you've gone through all of those steps. So what about outcomes after acute ischemic stroke in this population? Well, the first thing is, of course, as we all know, it can be difficult to predict in the first few hours of presentation, and that outcome can be changed by effective early reperfusion with thrombolysis or thrombectomy, or even spontaneous recanalization. Lots of literature on factors we know influence outcome. We know age and stroke severity are the major ones, and then a whole host of other features. I've just put a couple of them there: atrial fibrillation, either high or low blood pressure. And we also know that our interventions modify that outcome, so treatment with reperfusion therapies and stroke unit care. And there is evidence that comorbidity burden also is associated with a poorer outcome. So if we look at this review, which looked at presence of multiple chronic conditions and outcomes after ischemic stroke, to 18 studies, and found that most studies, just over half, reported a negative association of comorbidity with outcome, which you can see in this pooled analysis in terms of looking at the final outcome, categorizing people into the presence of multiple morbidities or not, and using the MRS standard modified Rankin score, 90 days, 0 to 1 versus 2 to 6, or 0 to 2 versus 3 to 6, showing that comorbidity is associated with a worse outcome. So we should be cognizant of that when we're thinking about our management and interventions. This is a small study where we explored this in a small data set when I was in Newcastle. It's unpublished except in abstract form, where we looked at, in a cohort of patients coming through, fairly small, just 71, the prevalence of frailty using a free criteria. Now, I won't talk about those. We modified it because one aspect of that is walking speed, so we adapted that to hand grip, disability, and multimorbidity measured by the Charlson Comorbidity Index. And in a multivariate model, we found frailty was independently associated with decline in MRS at 3 months, and quite markedly so. But the key thing I want to point out is that you do find people who are frail, who are not disabled, and do not have multiple morbidities, and you find people who have multiple morbidities who are not disabled or frail. And frailty was associated with a longer length of stay. And so just to point out there, there are these different assessments of older people, which also are important. This is a larger study which looked at 230 stroke admissions and assessed pre-stroke frailty and comorbidity, and found that over half had pre-stroke disability, and at least a third had at least one marker of pre-stroke frailty using a simplified Rockwood index. And again, similar to our findings, they found a group of individuals who were frail but not disabled. So what's the influence of comorbidity on outcomes from other studies? Well, this was a US study in Duke, and again, looking at pre-stroke comorbidity in just over 130 women admitted with acute ischemic stroke, and adjusting for the two major drivers of outcome, stroke severity by the NIHSS assessment and age, and Hart-Charlson was independently associated with poorer 90-day scores. And the coronary disease and diabetes were independently associated with poorer outcomes. So there's some limitation of this study, but I think it, again, causes the general thing that our outcomes are going to be poorer in this group. And if you look at dementia, this is a Swedish study, and that was associated with worse outcome in people who had a stroke, which is, I think, unsurprisingly accords with our experience. What about our treatment? So first thing is in people over 80 years, we know very robustly from the meta-analysis of TPA trials that it improves outcome in people over the age of 80 years. This was a controversy in the early days, and we published data showing the safety, which I've not presented here, but also showing if you look at outcomes, they are worse for each decile. So that was showing people who are dead at the top, dependent and independent. And once you treat over 90-year-olds with TPA in a European cohort, only a fifth are going to be independent MRS 0 to 2 at 3 months after thrombolysis treatment, whereas if you treat people under 60, you're looking at 2/3 of patients. So a very big difference. But there is a treatment effect there, which is of the same magnitude in both young and older people. In 2020, there was you can look at the Blumke paper, which provides much more detail on this in the analysis of the 1,700 patients in the trials over the age of 80, showing clearly shifting good outcome, MRS 0 to 1 from 13% to 19%, which accords with that experience I just showed you on the upper graph. And that 90-day mortality was, I think I've got was not significantly different in the alteplase and the placebo group, just as we see in younger populations. And in the real world data, interestingly, they saw a greater number of patients who were achieving a good outcome in routine practice, which may reflect some differences in the population entered, or possibly some improvements in our general care. So what about the effect of multiple conditions, comorbidities on stroke reperfusion therapies? This is largely unknown. The RCTs did not record that, and certainly patients with pre-stroke disability, which would often be present in people with multiple problems, were excluded from the trials because it would impact on measuring the outcome on the MRS. So if you look at single comorbidities, none of them show a major impact on the outcome, and certainly not on the treatment effect. And we are seeing case reports coming in the literature now of patients with pre-stroke disability, generally pre-stroke MRS of 3 and 4, which I think are reassuring that thrombolysis is safe. And I've certainly thrombolysed many people with a pre-stroke modified Rankin score of 3. And the single center study reported here, Canadian Medical Association Journal, 112 patients with pre-existing disability. And there was an increased mortality, and quite substantially so, over doubled and a worse outcome, but no difference in the total proportion of those with either an MRS score of 0 to 1 or return to their pre-stroke MRS. So I think this is reassuring, but we don't have any systematic analysis of comorbidity burden on outcomes from TPA. But in general, I don't think it should give one concerns about any increased risk beyond that associated with age if there are no other factors such as anticoagulant drugs or dual antiplatelet therapies. If we look at mechanical thrombectomy, obviously we know again from the Hermes meta-analysis that thrombectomy is effective in over 80-year-olds. There's 198 in the original analysis. And we see good 90-day outcome is less, 14% in the over 80-year-olds compared to 30% in under 80. And mortality is higher, which is entirely what we'd expect. Meta-analysis in 16 observational studies in a much larger number of people, 4,000 people almost, shows comparing over 80s to under 80s, which we're here taking as a surrogate for multiple problems, that 80-year-olds have worse functional outcome, higher mortality, only a small non-significant trend to a higher rate, and a successful recanalization was slightly lower. And I think this relates to some of the tortuosity of blood vessels and access issues that you see in many older people. But you're still seeing on these a successful technically, when you look at the numbers who achieve on the left column there, over 80 recanalization, we're talking about a small decrement in terms of the absolute effect of the treatment. This is a recent analysis from the German stroke registry, which is looking at over 90-year-olds. So this is 200 patients, and technically they achieved TICI 2B or more, the standard measure of recanalization in 76% of patients. So that is good. A good functional outcome, and this was a generous measure of good functional outcome, a modified ranking score of 0 to 3, not 0 to 2, was only there in 22%. And if you look at the even those who recanalized on the bottom grotto bars, as we often refer to them, if you look at 0, 1, 2, they're only 15% had a good outcome by our standard outcome measure. In-hospital mortality was high, and 90-day mortality was even higher, at almost 50%. But symptomatic ICH reported in this study, albeit not with independent reading, was only 3%. What about malignant MCA infarction and hemicraniectomy? This is controversial. I think in the UK, and certainly in my own practice, we are very conservative about putting forward people over the age of 60 years because of the data I'm going to show you. The Destiny 2 randomized controlled trial undertaken in Germany clearly showed in patients over 60 that you increase survival. But when you look at the numbers of patients who survive without significant disability, let's say modified ranking score of 3, it's extremely, extremely small. It's 7% in this very elderly group. And if you look at a meta-analysis of 14 studies, the MRS greater than 3 was 88% versus 67% in the over 80-year-olds compared to the under 60-year-olds. And in a US database program, looked a little bit better, 1-year outcomes with 55% mortality. And the survivors, only a third were in full-time long-term care facilities. So the rest were being managed to be cared for with support in-home. But if you undertake hemicraniectomy in this group, you're going to see very poor outcomes generally. And it's important that those conversations are had about the likely outcome with all our treatments, with families and the patients themselves where possible. I thought I'd present a case, though, which illustrates the complexity of treating older people with multiple problems. This was a 72-year-old lady who I saw in the emergency department a few years ago. She was called urgently. She had diabetes, hypertension, pseudo-obstruction, seizures, cataracts, and she'd had a previous stroke about 10 years beforehand with a right MCA stroke, leaving her with residual dense left hemiparesis and left homogeneous hemianopia. She lived with her family. She was bedbound. They were a very supportive Asian family, and you could argue she probably might not have been bedbound if, or shouldn't be. She should might have been able to do a bit more for herself. But she was able to communicate with her family. She could feed herself with the right hand, but she was required constant care and was immobile without family assistance. And she'd last been seen well that morning, and we had that witnessed. She'd been well, some went back and found unable to speak with right-sided weakness. So she'd had a stroke in the opposite hemisphere. She came in quite quickly. When I was called and had the brief history, I thought, well, this is not somebody I'm going to thrombolize. And she was mute, aphasic, and had right face arm leg weakness. Her NHSS was 25, but the new deficits only scored 7 as we could assess them. I assessed her. CT scan was showed no contraindication to thrombolysis, no early ischemic signs. So this was in the days before we would have to think about mechanical thrombectomy. And you might think whether you would offer a patient like this thrombolysis. And I spoke with the son and said, what's her quality of life like? And he said, oh, it's good. She enjoys life. She's got a family around her. So we made the decision to thrombolyse her, and I think I treated 3 people that week with thrombolysis. She was relatively late in the window, but within 3 hours, and she resolved completely, just had a bit of hemorrhagic transformation. So she was discharged home on the 2nd day after admission, full resolution, but outcome is still a modified ranking score of 5. And that's a poor outcome, but you can argue for her and her family, it isn't. I'm just finally going to, before I come to the final slide, just talk a little bit about palliative care. This group, older people with multiple problems, has a very high mortality rate, as you've seen. There's a limited literature on palliative end-of-life care, but we have to think about it when we're faced with a group of people who have a very high in-hospital mortality. There are some useful papers in the literature, and certainly I think it's very important, certainly about 24 hours, to explain to patients and family what the sort of best and worst case scenarios are to help frame potential outcomes and discussions. And the sort of asking the patients or families what they understand, and sort of telling them, and then again testing their understanding. What's called the ask, tell, ask approach is quite a good framework to use. I'm quoting some data from a small study of palliative care needs. So this is not end-of-life needs, it's palliative care needs on a stroke unit, and in an older population with over half over 75 years, 80% more than 2 comorbidities, 50% reported fatigue, 50% had symptom-related problems like pain or psychological distress, 1/4 were concerned about death or dying, and 2/3 had concerns about dependency and disability. So these are issues we need to talk to our patients and families about. And over half were worried about the impact of stroke on family members. And dependency, age, and comorbidities were predictors of the need for palliative care in terms of specialist palliative care team input. This is slightly out with the initial care of acute ischemic stroke, but this was a study my colleague Helen Rogers did, which randomized people who were disabled at discharge from hospital. So they were receiving early supported community stroke rehab support, and they were randomized to receive extra follow-up or routine care after they received their treatment. And it was a sort of holistic review where a member of the team contacted patients every few months, asked them how they were doing, what their needs were, and then directed them to input, which might have been rehabilitation, but wasn't always. They chose the primary outcome was the Nottingham Extended Activity of Daily Living Scale, which did not change, but there was a change in the modified ranking score at 2 years, which was interesting. And there were fewer cases of anxiety and depression, and there was less healthcare resource utilization. So this fairly simple intervention actually reduced healthcare costs, and on quality of life measure, patients felt better. Maybe this sort of holistic support approach is what we need to think about for our patients, even though it was a secondary outcome, not a primary outcome in this trial. So this is my last slide, just to summarize my sort of approach is take a careful history, establish a pre-stroke function, understand what the patient was like before they had their stroke, think about mimics, provide acute stroke unit care. I haven't talked about that, but stroke unit care is of benefit at all ages. And in terms of helping prevent complications of stroke, monitor patients carefully. I haven't gone through this, but they are at higher likelihood to develop complications because of their underlying medical problems. Reperfusion therapies are effective, so no reason to deny them, but you've got to think of the context and what the overall outcomes are. My advice is to be very conservative about offering hemicraniectomy to this group of patients and think about patient wishes and available community support. Provide palliative care, and where it's needed, I haven't talked about it, we need to provide end-of-life care, although this is challenging on stroke units due to the nature of the ward being very busy and very interventionist. And thank you. I'm very happy at the end of the session to take questions, of course.
Thank you, Professor Gary Ford. Very interesting topic, very challenging topic to cover with the elderly age and acute stroke. Sure, there will be plenty of questions at the end of the session. So we will go to our second speaker, then we will ask all the audience to put your Q&A in the Q&A box. A few questions regarding the CME. CME will be sent after 2 weeks from the seminar. So please enjoy the second speaker. I would like to welcome Professor Eric Edward Smith. Dr. Smith is the medical director of the Cognitive Neuroscience and Clinical and a member of the Calgary Stroke Program. He's a professor in Department of Clinical Neuroscience at University of Calgary, and he's mainly chairing the vascular dementia program in Calgary. He did his MD degree from McGill University and completed his neurology residency program at MG Hospital and Birmingham and Women's Hospital, teaching hospitals of Harvard Medical School. Dr. Smith, research program investigators for the risk factors and consequence of diseases of cerebral microcirculation, and with the goal of improvement in diagnosis, prevention, and treatment of vascular, cognitive, and dementia. He has received the Robert Award from American Heart Association for his research work. Currently, he is a member of Stroke Editorial Board and Editorial Board of Journal of Neurology. His main area of interest is cognitive neuroscience and stroke prevention. Welcome, Professor Smith, and his topic will be about the vascular dementia pathophysiology, risk, and prognosis. Zoom is yours, Prof.
Thank you very much. Just bring up my slides here. There you should see them. Thanks for the lovely introduction. It's my pleasure to be here. I'm just going to switch my camera to the right one there. Okay, thank you so much for the introduction and the opportunity to speak to you about this topic on vascular dementia. I'll start with a description of my disclosure. So I have grant funding from Canadian public funding sources for research on this topic. I run a MRI core lab that provides services for MRI measurement of cerebral small vessel disease to these Canadian universities here. I receive royalties from Up to Date for writing a section on vascular dementia diagnosis, and I've done consulting for companies on clinical trials for vascular cognitive impairment and cerebral amyloid angiopathy, which is one of the cerebral small vessel diseases that causes vascular cognitive impairment, or VCI. And during this talk, we'll talk about strategies for preventing small vessel disease that are not labeled indications. I'd like to thank my research team who has supported my work, some of which we'll show you here. This is a picture from our Christmas party the year before COVID hit. And I'd like to thank my collaborators at the University of Calgary too, Richard Frayne and Marina Saluzzi. And what I'll talk about today is vascular cognitive impairment. I'm going to talk about the definition, not so much about screening, although maybe what will come up, kind of as I go a little bit. We'll talk about the different VCI clinical syndromes and settings in which you see it. We'll have some focus on post-stroke cognitive impairment, which to stroke neurologists like me and you is the most common setting where we're going to encounter this. We'll also talk about VCI without recent stroke, and then current ideas on treatment. So vascular cognitive impairment is an umbrella term. It's a little hard to find an exact definition in the literature. I think Ditchkins and Less maybe defined it the best when they said it refers to all forms of cognitive disorder associated with cerebrovascular disease, which means including different ranges of severity of cognitive disorder. In cognitive disorders, we typically discriminate them as dementia, meaning there are cognitive impairments that are causing decreased functioning in basic or instrumental activities of daily living. In other words, there's a cognitive disability. There is a pre-dementia syndrome or an at-risk syndrome or a milder form of cognitive syndrome called mild cognitive impairment, which is defined as the presence of objective evidence of impairment, that in the context of VCI could be documented, for example, by using the Montreal Cognitive Assessment, which is a cognitive screen that includes tests of executive function to which persons with VCI are predisposed to have those executive impairments. But in contrast to dementia, in MCI, the cognitive impairments are not leading to significant impairments or decline in instrumental and basic activities of living, such that the patient is still essentially independent. These syndromes are also have the syndrome of major neurocognitive disorder for dementia and minor neurocognitive disorder for MCI as operationalized in the DSM, the Diagnostic and Statistical Manual of Mental Disorders. Some people additionally identify a cognitive stage called subjective cognitive concerns or decline, where there are symptoms of cognitive decline, but in the absence of any detectable impairments on testing. And then VCI accompanies any form of cerebrovascular disease that's led to vascular brain injury or brain dysfunction, leading to one of these syndromes. So as defined by Ditchkins, it refers to all forms of cognitive disorder associated with cerebrovascular disease, regardless of the specific mechanisms involved. So really any cerebrovascular disease that causes brain injury or dysfunction can lead to this, including ischemic stroke and hemorrhagic stroke and all the different cardiac and vascular and cerebrovascular pathologies that lead to these stroke. And it encompasses a full range of cognitive deficits from mild cognitive impairment to dementia. And then we see VCI in two common clinical settings. So one is in the setting of someone who's had a recent stroke, which I'm listed here as post-stroke. This is where maybe the link between cerebrovascular disease and the cognitive impairment is most obvious, because you have a patient without cognitive symptoms before stroke, or at least at a certain level of cognitive functioning before stroke, and then a stroke occurs, and after the stroke, they've had a decline in their cognition. The pathophysiology, this most includes either ischemic stroke or hemorrhagic stroke. Among the ischemic stroke causes of post-stroke cognitive impairment, we see a distribution of stroke syndromes that's similar to, or stroke mechanisms that's similar to what we see with stroke overall. So much of it is caused by cardioembolism or large artery disease, and a minority by small vessel disease. There's another important setting and scenario where we see VCI, and this is where we see VCI without a recent stroke. And these patients are more commonly encountered in the dementia clinic or in the general neurology clinic. There is not a history of stroke concurrent with or immediately preceding the cognitive decline. The cognitive decline may be progressive and smooth, mimicking the course of a neurodegenerative disorder like Alzheimer's disease, for example. But then when brain imaging is done to exclude other causes of dementia, what you see are either multiple small infarcts or confluent white matter hyperintensities or other forms of cerebrovascular brain injury that indicate that vascular disease is at least partly responsible or wholly responsible for the cognitive decline. And when you look at the distributions of pathologies in this group of VCI without recent stroke, one finds that it's predominantly small vessel disease that is causing these clinically unrecognized changes in the form of arteriolosclerosis due to aging, hypertension, and other cardiovascular risk factors, or cerebral amyloid angiopathy, which is a small vessel disease caused by beta amyloid accumulation in the walls of the small arteries and arterioles. So let's talk about VCI after a recent stroke, and I'll start with a case presentation. So this is someone I saw in follow-up in the clinic after providing care for her while she was admitted acutely to the hospital. She was 71, and she presented acutely with confusion, vomiting, a left hemianopia, a left hemiparesis, and a skew deviation. Posterior circulation signs, suggesting potential posterior circulation disease. And in fact, a CT angiography showed that she had an occlusion of the distal portion of the basilar artery. She went for endovascular thrombectomy, and the thrombus was successfully retrieved with good reperfusion. She had recovery of her hemiparesis, and her extraocular movement abnormalities resolved. So the brainstem signs essentially went away. But 3 months later, I saw her in clinic, and she was exhibiting persisting forgetfulness. She was independent with basic tasks and was fully mobile without any residual weakness. but she was no longer able to shop for herself, prepare meals. She couldn't do her finances. She could not drive. She required help from family. Modified Rankin Scale score was 3, but in this case, entirely due to non-motor related deficits. And on this MRI DWI on the right, you can see the reason for this cognitive syndrome. There is infarction in the medial posterior cerebral artery territory in both hippocampi, which, as you know, play an important role in encoding and retrieval of memory. So she had a very focal amnestic syndrome that prevented her from shopping and doing these other tasks. There was some occipital lobe infarction as well. So this is an example of how cognitive impairments after stroke can sometimes occur in the absence of motor deficits, and sometimes can make the difference between returning to normal independent life or having persisting stroke-related disabilities. There's an excellent review of the prevalence and incidence of post-stroke cognitive impairment and dementia by Peter Rothwell and Sarah Pendlebury. It's getting a little bit old, published in 2009, but it remains probably the best, most comprehensive survey. What they found is that prior to stroke, about 10% of patients with ischemic stroke have a history of dementia that preceded the stroke. About 10% have new dementia after the stroke. And over the next 3 years, about 10% will progress to dementia, which is a higher rate of progression than in the general population. So I kind of think of it as a rule of tens. What's changed with the epidemiology of VCI after stroke in Canada and the United States is that with a fairly rapidly changing demographic, with an aging population, the proportion of patients with dementia who have a stroke is probably higher now. Based on my own experience and practice, I'd say it's probably closer to 15 to 20% of the patients we see with stroke have a history of preceding cognitive impairment or dementia now. And when you look at what the determinants of post-stroke dementia are, you find, there's a number of factors, some of them related to how healthy the person was before the stroke. So things like age, education level, presence of medial temporal atrophy, which could be a proxy of prior covert cerebrovascular disease or Alzheimer's disease, are all related to risk for post-stroke cognitive impairment. But the strongest risk factors are related to stroke severity and location. So these data are from recent publication from the population-based study in Oxford led by Peter Rothwell and Sarah Pendlebury. And this is a survival curve showing the cumulative incidence of post-stroke dementia according to different stroke severity. The light pink line here is TIA, and then increasing levels of severity. This is NIH stroke scale, minor ischemic stroke with NIH stroke scale score of 0 to 2. This is NIH 3 to 5, 6 to 10, and greater than 10. And what you can see is a very strong graded relationship between higher stroke severity and higher risk of post-stroke dementia. The risk is all within the first few weeks or few months. After that stroke recovery period is over at 3 to 6 months, the curves are roughly parallel after that. So all of the effect of stroke severity is really in how much damage there was and how much it limited recovery. And you can see that this graded relationship exists even between ranges of stroke that I would call kind of within the mild to moderate range, like the upper curve is NIH stroke scale score over 10. So even our patients with minor ischemic stroke are at fairly high risk of post-stroke dementia and subsequent stroke risk too, as I'll show you. Dementia risk too, as I'll show you in a later slide. So then the other factor is location, of course. We know that stroke location, is a major determinant of all kinds of symptoms after stroke, and cognitive impairment and dementia is no different. These are data from a pooled analysis of several cohorts collected by the META-VCI consortium and published in the Lancet Neurology this spring. So these are brain maps which are based on voxel-wise lesion symptom mapping. So basically you take the MRI scans of a cohort of patients, some of whom have post-stroke cognitive impairment and some don't. You use computer software to overlay all the scans on top of each other. And then you look at which locations in the brain, when affected by an infarcted voxel, are correlated with risk for post-stroke impairment. And that is shown in the bottom image here. And the color scale here is on an odds ratio scale. So colors that are more toward dark purple and away from green indicate where there are higher odds of post-stroke impairment if that area of the brain is affected by infarction. What you can see is that both anterior temporal lobes, the peri-insula region, including the inferior frontal lobe, the anterior temporal lobe, and the insula on the left side, the inferior frontal lobe, and to a lesser extent, the posterior temporal lobe and inferior parietal lobule on the left, and the right temporal lobe, including the parietal lobe, where areas are specialized for spatial functioning and reasoning. Infarcts in all of these areas are related to risk for post-stroke cognitive impairment. With regard to what we saw in our patient, you can see that areas of infarction that affect the left hippocampus are associated with moderately elevated odds of post-stroke cognitive impairment and dementia. In my patient, it might have been so bad because both medial temporal lobes, right and left, were infarcted. Some regions are, we think based on clinical experience, are probably related to post-stroke impairment, but aren't demonstrated in this slide. The power of these voxel-based analyses depends on the sample size for each voxel, and the slides on the top indicate the total sample size at each voxel, with more yellow-orange colors indicating higher sample size and thus better statistical power. So they didn't have a lot of coverage in areas of ACA territory, which is why they maybe do not show any significant voxels there. But it is felt clinically that ACA territory infarctions, particularly when they're bilateral, can be associated with post-stroke cognitive impairment. And it's also well known they're associated with abulia, for example. These are data from the REGARD study, which is a large American study of about 30,000 people. It's a prospective cohort study. They're followed over time for occurrence of stroke. And then a very simple cognitive screening task called the 6-item screener had been done before stroke. And in those who had a stroke, they had it also after stroke. So you're able to map pre-stroke and post-stroke trajectories. Now, this is a very simple screener, so people with normal cognition are expected to score perfectly on this screener, which is why you see in the control population with who did not have a stroke during the course of the study, the dashed line indicates no change over time from 0 to 10 years of follow-up. These are model predicted values based on their modeling where the occurrence of a stroke, modeled here, an individual where a stroke occurred at 4 years, you see the stepwise decline in the 6-item screener. This on the left, sorry, this is younger persons less than 65. On the right are persons over 65. The dashed line indicates the expected 6-item screener score after stroke in the control population, whereas the red line shows the change in 6-item screener score in those who had a stroke. So you can see not only is there a stepwise decline, on average, when someone has a stroke, their cognitive function declines. You can see their future cognitive course is altered too, with a greater rate of progression to dementia or loss of score items on the 6-item screener in the future. So we're just beginning to explore why some people have this kind of late post-stroke dementia. This is from a review article in Nature Reviews Neurology, finding that essentially the determinants of early post-stroke dementia are stroke severity and location, to some extent also the degree of cognitive reserve that the patient has. For delayed onset post-stroke dementia, the contributing feature seems to be either risk for recurrence. When there's a recurrent ischemic stroke, the risk for post-stroke dementia is much higher than for an initial stroke. And some of the risk also seems to be related to sporadic small vessel disease and its progression. Which brings me to VCI without recent stroke, which is predominantly caused by small vessel disease. Here's another case example from my clinic. This was a 65-year-old man who presented with cognitive slowing, forgetfulness, decreased gait speed. He had poorly controlled hypertension, unable to do his own finances and shopping. VOCA was low at 14 out of 30. The threshold in Canada is 26 to 30 is defined as normal. And exams showed, some kind of soft signs suggesting long tract dysfunction with some mild hyperreflexia and clonus in the ankles. It didn't have a history of stroke, but a brain scan showed extensive white matter hyperintensities and shown by the double arrow, and multiple lacunes, an example of which is shown by the single arrow. So cerebral small vessel disease, we're understanding more about its mechanisms, and it has really diverse manifestations within the brain. In early stages, we believe it's marked by both presence of loss of vascular integrity as well as ischemia. The loss of integrity leads to findings like microbleeds, whereas the ischemic manifestations include in later stages infarcts and microinfarcts. Lack or disruption of blood-brain permeability is another feature of small vessel diseases. In the beginning stage, you can see even subtle edema, sometimes in the white matter, as well as subtle leakage across the blood-brain barrier on contrast images. As this progresses, you see that white matter hyperintensities appear and grow. You begin to get infarcts, and these infarcts and disruption of the white matter microarchitecture begin disconnecting brain regions from each other, as well as descending tracts that affect, like, say, gait control, for example, which is also disturbed in these diseases. And this leads to cognitive impairment, gait impairment, and neurobehavioral impairments. We can classify manifestations of small vessel disease on MRI using the standards for reporting vascular changes on neuroimaging, or STRIVE, which was a project that I co-led with Joanna Wardlaw from University of Edinburgh and Martin Ditchkins from Ludwig Maximilians University in Munich. And this provided standards for defining and describing the cardinal manifestations of small vessel disease as recognized at the time, which were recent small subcortical infarcts, white matter hypertensities, lacunes, perivascular spaces, and cerebral microbleeds. Since then, we've recognized with quantitative imaging many more manifestations. For example, we can quantify alterations in brain diffusion using diffusion-weighted or diffusion imaging. We can measure cerebrovascular activity. We realize that microinfarcts, which are small cortical infarcts, are another manifestation. And so we've reconvened the STRIVE group and are working on a revision to an update of these criteria, hopefully to appear in the publication next year. So how do we manage these patients? These are the general principles. So if it's a person with a stroke, we want to rehabilitate their stroke-related deficits. There's some evidence that cognitive rehabilitation can be done and can improve attention, for example, after a stroke. We have to take steps to accommodate people's disabilities. That includes potentially providing home care services, advanced care planning, including designating a legal representative to help manage finances and other aspects of their life. It includes assessing safety, including safety for driving, as well as protection from financial scams. There's moderate evidence that cholinesterase inhibition with medications like donepezil or ribostigmine or galantamine, or also the cognitive enhancer memantine, may provide some cognitive benefit, although it's only about half the benefit that was seen in trials for Alzheimer's disease. And the effect on quality of life and function is, the data are less strong and somewhat controversial. So we typically don't use these medications frequently in Canada. One has to prevent stroke, and there's strong evidence that recurrent strokes increase cognitive risk. Enhancing cognitive reserve, could mean things like physical activity, cognitively stimulating activities, and the idea is that they increase synaptic density and allow better functioning brain networks that can compensate for damage from stroke. And finally, something we don't fully understand is how to reduce the progression of small vessel disease, so that we do have some evidence that controlling blood pressure is important. We just published a paper in neurology looking at cross-sectionally the interaction of cognitive reserve on the relationship between brain infarcts and white matter hypertensities and cognitive impairment. And we failed to find an interaction. So from what we can tell, cognitively healthy things like being married, participating in a social group, being physically active, while they are good for cognition, they don't seem to ameliorate the ill effects of covert cerebrovascular disease with brain infarcts and white matter hypertension. So public health strategies should promote things like early life education and cognitively enriching environments, but they're not. We also need to prevent stroke and prevent progression of small vessel disease. Aside from stroke prevention, we don't really have other evidence currently for specific treatments targeted against the pathophysiology of BCI. This is from a systematic review that was published by my group in the Journal of the American Heart Association in 2017. So it's a little outdated, but there haven't been any landmark trials since then either, I would say. What we did, or what we found when we systematically reviewed the literature, is a series of trials in the 70s and 80s that were kind of a small scale with pre-modern clinical design looking at vasodilators, followed by some larger trials. The x-axis is the sample size of the trial, and the y-axis is the year. The size of the bubble is it was really the sample size of the study, and the colors related to the mechanism being investigated. In later years, we did find some larger scale trials, basically testing Alzheimer's treatments to see if they also work for BCI, with, as discussed, some modest success. These were all the different medications tested. The only phase 3 trials that weren't of Alzheimer's medications were propentafilin, which is a phosphodiesterase inhibitor, and naftidrafural, which is a calcium channel blocker, neither of which really had a strong signal on phase 3 and were not significant. So we need some approaches. The one thing that we do know probably works is reducing blood pressure, as shown most recently in the SPRINT MIND study, where patients randomized to more intensive blood pressure lowering had less progression of white matter hypertensities. They also had less risk of MCR dementia, although there was no mediation analysis to see if that was mediated by the white matter intensity progression or not. And then I've recently reviewed, along with you, Marcus, trials of new approaches, which include using antihypertensives and vasodilators. It's kind of an old approach, but what's changed is now we have modern methods of using brain imaging to look at effects on surrogate markers like reactivity, blood-brain barrier permeability, and diffusion. Physical exercise, remote ischemic conditioning, and miscellaneous approaches. What we're trying in Calgary is this technique called remote ischemic preconditioning, which is based on studies from the 80s in animal models of myocardial infarction. They found that if you condition the animal before inducing the infarct by temporarily occluding the coronary artery, you can induce changes in the tissues that limited the infarct size when you permanently occluded the artery. And the kind of miraculous thing is you can also induce this protective effect by doing ischemic conditioning on an organ remote from the heart. So for example, you can inflate a blood pressure cuff in the arm to cease blood flow to the forearm, and that releases signals, both neural and humoral, that induce changes short-term from vasodilators and other molecules, but also long-term by altering gene expression of heat shock proteins, anti-apoptotic proteins, and others, with the idea that introduces tolerance to ischemia in the heart, but also in the brain and other organs. In an animal model of vascular dementia, animals treated with this preconditioning on their hind limb with a blood pressure cuff had an increase, a rescue of most of the drop in cerebral blood flow in a bilateral carotid occlusion model, as shown by the green bar compared to the blue bar here. Their capillary density increased. They had less loss of myelin after occluding both carotid arteries, and they had normal rat cognitive test values. So we're testing this in people in a pilot study, just looking at adherence and tolerability. This is a very easy, effective therapy to apply because all you need is a blood pressure cuff modified to maintain inflation above systolic level on the arm for 5 minutes, followed by deflation, and then you go through 4 to 5 cycles of this treatment. So it takes about 35 minutes a day. We're testing the tolerability of 2 groups. One has a single treatment per day, one has 2 treatments per day. And this treatment has been used in a few other small trials, suggesting that it might reduce progression of white matter hyperintensity volume. It's been tested in other settings too, and it's not approved for use in any specific scenario. Ischemic conditioning has been tried before major cardiac surgery. It's been tried at the time of MI or stroke, where the data are mixed. A large trial in patients with acute myocardial infarction published in The Lancet in 2019 was neutral. However, those were examples of what's called perconditioning, where the therapy is applied like while you're having a heart attack, which never made a lot of sense to me, because if you already have ischemic myocardium, I don't think you need to signal from somewhere else in the body for the myocardium to protect itself. It's like actively ischemic now. Plus, if you apply the therapy while an event is happening, you know, the effects you get from changing gene expression, which might evolve over hours to days, you know, won't have time to take effect before the myocardial infarction is complete. So I think preconditioning, you know, there's more rationale for use in that setting. And COVID has caused lots of disruption. So we're about a quarter of the way through the pilot trial, where we're just testing 12 patients in each group. So in conclusion, VCI is a heterogeneous syndrome where the main clinical settings in which we see it are after a stroke, or in the clinic where it's where vascular disease is recognized in a brain scan in somebody without a recent stroke. For early post-stroke dementia, the main determinants are severity and location. For later post-stroke dementia, we think the determinants are mostly risk for recurrent stroke and progressive small vessel disease. For the VCI without recent stroke, the main cause is progressive small vessel disease, where we know that blood pressure control is important, but clinically I still see patients with progressive lesions despite blood pressure control. So there are other aspects of the pathophysiology we don't understand, and I think in the future we'll have different types of treatments for these patients. So I'll thank you very much. I'll turn it back over to the chair, and happy to take any questions. Thank you.
Thank you, Prof. Smith, for this nice presentation. We'll start with the questions to Dr. Prof. Gary Ford. Is about risk factor for hemorrhagic transformation in frail elderly patients.
Thanks, you should be able to hear me. Hemorrhagic transformation occurs, I mean, usually within the first 24 hours, which is why we do the follow-up CT scan, for example, in people who have thrombolysis with TPA or another agent, or undergo endovascular thrombectomy, routinely at 24 to 30 hours, unless they deteriorate before that. I think it's important to be clear that only certain types of hemorrhagic transformation are important. We know blood pressure is a risk, and age and stroke severity, but if you use the classification that we use, HT1 and 2, PH1 and PH2, diffuse petechial hemorrhage is of no consequence in terms of clinical recovery. The hemorrhage that matters is the parenchymal hemorrhage 2 and occasionally parenchymal hemorrhage 1. Between 1 and 2 is 2 occupies a third or more of the established infarct volume. And they are associated with neurological deterioration. So generally, you don't need to be too concerned about it after the first 24, 48 hours, and we would start antiplatelet therapy, for example, in somebody who'd had thrombolytic therapy at 24 to 48 hours if they didn't have major hemorrhage, with a parenchymal hemorrhage. I think the issue which is being addressed in ongoing trials is when to initiate anticoagulation in people with ischemic stroke due to atrial fibrillation, where traditional conservative practices, because of the risk of bleeding in up to 2 weeks on anticoagulants, to wait for 2 weeks. But a number of observational studies suggest early anticoagulation, some of those have been done with the new direct oral anticoagulants, is not associated with an increased risk. And there are a number of ongoing trials, including the Optimas trial, which I chair the steering committee for, which are randomizing people with ischemic stroke with AF early to or late. So to receive it within the first 4 days, start anticoagulation, or 2 weeks. So I think in the future, we'll have a better understanding of which patients we can start early anticoagulation to prevent recurrent stroke.
Thank you. Second question is about using gait speed to assess frailty in elderly patients. Is it a research tool or we can integrate in our clinical practice?
Well, I mean, your therapist will be looking at gait, of course, but in terms of using it as, which has been used in the research literature, look at frailty, and gait speed does correlate with mortality risk in a community dwelling elder population. We don't use that in our clinical practice. And in fact, it's certainly for assessing frailty in stroke patients. The problem is it's not suitable in many patients because of the limb weakness or gait problems they have, so you're not really assessing pure frailty, which is what it was developed for in people without focal neurological deficits. So probably a better measure if you're looking, but we haven't got a frailty measure standardized in our services, and the Rockwell ones are better rather than more sophisticated research ones such as hand grip strength and the like. But the Rockwell is a simple framework you can use to categorize patients, and it's probably helpful.
Okay,
I think I comment on that too. That because gait speed is very, it's cognitive speed is related to gait speed as well. And as Dr. Ford said, both these things are prognostic signs of risk for mortality, for cognitive decline. What you're going to do about knowing that they have increased risk, I guess, is a question that's a little challenging to answer. I do screen for gait speed. I have to admit, it's not with a validated research tool, but I'll often go out and get them, and I'll be watching when they walk from the waiting room to the clinic office. You can get a sense both of what the overall speed, also what the cause of the speed is, whether it's hemiparesis or it's in dementia practice, what's another gait that might indicate hydrocephalus or Parkinsonism or other things. So it's pretty informative, although I don't use like a formal test like the timed up and go with a stopwatch and a line, but I just use kind of observation, clinical judgment.
Yeah, I completely agree. I think it's very valuable to look at the patient walking in. It tells you a lot.
Thank you, Prof. Smith. The third question to Prof. Smith is how to differentiate between post-stroke cognitive impairment or vascular impairment and patient with global or receptive aphasia.
Yeah, this is a challenge, with taking the kind of research that's been done in the dementia world and porting it to the stroke world, because we have patients with aphasia. I think one positive sign is that in the new DSM, 5th edition definitions for impairment, they acknowledge that aphasia is itself a form of impairment, a form of cognitive impairment. So I think we have to acknowledge that. It is challenging, I guess, right? But it is clinically useful to get a sense of whether there are more global impairments outside of language, that might be impacting function, the community, and for which you might need to support the patient. Part of it, I think, is like just a detailed history of things they can or can't do, right? Some patients with pretty severe aphasia, with just a grunt or a single word, are able to function with pretty, fairly complex daily tasks like taking the bus to their appointments and this kind of thing. That indicates they have some level of intact executive function like planning and organizing and memory. I will occasionally do like most of our cognitive testing is verbal, right? So there's only so much you can learn when patients are nonverbal, but I'll try sometimes like a nonverbal memory task if I want to interrogate this, just a very simple, I'll take a $5 bill and say, I'm going to hide this somewhere in the room. And if you can point to where it is at the end of the interview, you get to keep the bill. Usually they donate it back to me. Some of them keep it though, and then I'll hide it somewhere. This relies on some degree of intact comprehension though, of course, right? The attention and comprehension, if both of those are impaired, then it's quite challenging other than simple observation, because really our whole neurological exam is based on having some level of attention and comprehension.
Thank you. Another question is about difference in cognitive impairment post intracerebral hemorrhage compared to ischemic stroke.
Because intracerebral hemorrhage is overall more severe, the risk for cognitive impairment tends to be higher. Let's see, I don't know if there's literature to back this up, but if patients with ICH survive, at least for motor outcomes, there is some suggestion that they may have greater chance for recovery, right? Like once the hematoma resolves, sometimes you see a slit-like cavity with some surrounding gliosis. It's not necessarily as destructive, but you get these acute effects from, like pressure, as well as potentially all these toxins, from the blood breakdown
Yes.
products causing peri-ICH inflammation. So I think the answer is like overall, because it's more severe, you're at higher risk for post-stroke impairment, but for patients that survive the acute period, there may be some better chance of recovery.
Another question is about using aspirin and statin in patients with silent small vessel disease. So you just see a patient in the clinic because of headache or because of mild cognitive impairment, and you found multiple lacunar infarctions. Do you use aspirin?
I guess the answer is sometimes, and it reflects the fact that we have sort of incomplete evidence, without clinical trials focused specifically on this question. There are some consensus statements around this, like I led a writing committee for the American Heart Association that released a scientific statement published in Stroke in 2017 on prevention of stroke in patients with silent cerebrovascular disease. What we concluded is there was kind of insufficient evidence to support the use of aspirin in everyone in this population. And then, of course, generally speaking, in the general population for primary prevention, things have moved away from aspirin for primary prevention based on the newer generation of trials, including Esprit, which is like aspirin in the elderly, that showed that starting people on aspirin didn't prevent stroke, didn't prevent dementia. And, there is a small risk of like GI bleeding complications, right? And of course, some of these patients in the primary prevention trials, maybe up to 20% might have had silent lacunar infarcts. The problem is like, we just don't know which of them did or not. So I do individualize a little bit. One thing I don't do is for patients that just have white matter hyperintensity, high white matter hyperintensity burden or white matter hypodensities on CT, I don't start aspirin in that group because we know less about the pathophysiology of white matter disease. In the elderly, some patients with white matter disease have cerebral amyloid angiopathy, where aspirin is probably not helpful, might even be harmful. For patients with cortical infarcts or potentially with like multiple lacunes, and for patients that are maybe having clinical symptoms, like subtle clinical symptoms from the lacunes, I probably would start aspirin, but again, it's kind of, you have to individualize things, I guess, based on patient risk. We do know that patients with a silent brain infarct are at increased risk of future ischemic stroke compared to the general population. It's about a twofold increased risk. So that might motivate you to use aspirin on kind of the basis that they have a higher risk.
So if I will ask you a question, Professor Smith. Today I had a patient who's 55, healthy, had a brain scan, came to my clinic, MRI, non-smoker, non-hypertensive, not diabetic, borderline LDL, and he had at least 7 white matter lesions there, which looks like a vascular in nature. Okay, but nothing. And he claimed that his mother had a dementia in her 65, 70, and he's 55, and he's concerned, is these white matter is going to be mother in a pipe of 10 years, 15 years? Shall I be on aspirin? Shall I be on statin? What shall I do to prevent this from happening? Today I had that patient.
Yeah, well, that's the reality. And I wish we had an evidence base where I could say confidently it's clear as anything, just go ahead and do this or that. And these are hyperintensity. In other words, you wouldn't call them infarcts, I guess. They weren't like cavitated lesions. They were these bright spots on T2 weighted imaging, like FLAIR, I suppose. Yeah. Well, as I said, I would not, because we're not sure what generates these things or whether it's mediated by thrombosis. I wouldn't counsel aspirin in this case. I'd look at the rest of the risk factor profile, which is kind of mild, actually, I guess. It really just has borderline LDL, you said, and otherwise no other vascular risk factors. So his 10-year predicted risk of like MI and other vascular events is probably still fairly low, although the presence of white matter changes in the brain, would elevate that risk somewhat. So I'd probably focus on, it may be like, well, I know all this already, but, a renewed focus on eating a healthy diet with some evidence for a Mediterranean style diet, physical activity, engaging in cognitively stimulating, hobbies and this kind of thing is probably a better course of action. than medications, although, depending on what is future risk, 10-year risk is, you might consider the statin if you feel that knowing his risk is somewhat increased might kind of, move him over the threshold into starting with a statin. But yeah, no, these are very practical questions for which we need better evidence for better answers.
Thank you. That will take me to our questions to Professor Ford. In the GCC and Middle East, we have a huge number of young population in their 30s, 40s, hypertensive, diabetic. How can we promote a healthy awareness for these patients to prevent the end stage of having these type of stroke and to have a vascular disease at the end? What you did in UK, which is very, very important to learn. Any message from there?
Well, I think two things. I mean, prevention is absolutely key. If I could do myself out of a job and not need to be an acute physician, it'd be a great achievement. It's unlikely to happen. But I think what we do know more seriously is that primary care services are key, and community programs of action are key to effective prevention. So they have to be developed in the context of your overall health system, education at schools. I mean, we are facing a problem of increasing childhood obesity, for example, and that's feeding through into the problem you described, although probably to a lesser extent than in your country, of early onset type 2 diabetes in people in their 20s and 30s, which we virtually never used to see when I was first training. So I think the message has got to be simple. In terms of stroke prevention, blood pressure control is absolutely key, and then prevention of diabetes, which comes down to diet, activity levels. And I do think we tend to try and address these problems too late as a health system, and secondary prevention is really important in all our stroke patients. But really, the problem you refer to is a community problem. How do you get children to exercise? Not be driven around everywhere. I don't know what the solutions are for your own country, but it has to start out in the community and with your primary care colleagues.
Which I believe, Dr. Mohammed, that MENASO need to work on that one to increase the public awareness in the region about primary prevention. We are focusing a lot on secondary prevention, on acute treatment, on how to prevent vascular dementia, but there's something that we need to focus on governmental, the decision maker, how to increase the salt intake so the BP will be less, how to do more exercise to the kids in their classes, in their school, building gym in our community, which is, we are a little bit slow in doing this at the level of the country. Professor?
Would it be okay if I make a comment too, just briefly, that we looked at this in Canada. We looked at the population of people at risk for different risk factors, like at different ages, and for stroke, in a large Canadian database. Is under review, and hopefully you'll see this eventually in a stroke journal. But what we found was smoking was like a big factor. It's not that common in Canada, but it accounted for the largest portion of early, stroke risk in young adults, in the 30s, 40s, was smoking. So it depends on its prevalence in your countries, but that might be something to consider as well.
Yeah, really good point. We don't think about it so much for the same reason. It's much less common now in the UK.
There's very, very nice question regarding the contraindication for TPA in elderly patients. You presented a case for a patient who presents with acute stroke. Many of our community neurologists will be concerned about giving acute thrombolytic agent or going more aggressive with the mechanical because, Suhail, they have low platelet count. Microbleed may be there. We did just a CT. We don't know about the microbleed. Patients on antiplatelet and the risk of a bleed. Is there any evidence that the benefit of acute treatment for acute stroke is far away better than not to treat?
Yes, I mean, in general, I think the answer to that is a very clear yes from the data I presented from the randomized trials, and then the data from large observational series, of which there are a lot now. So the first thing is that if you follow the general exclusion, so you don't treat people with blood pressure above 185 over 110. And don't treat people who are fully anticoagulated. I mean, although that's an area of controversy, or with blood on the scan, those are absolute contraindications at any age. It would be a generalization, but the best one to follow. We went through this. We were very conservative in the UK, Europe, and I think to some extent in the US about treating older people. Mainly because European trials had an artificial upper age limit of 80, the first European thrombolysis studies. But the key issue is it's effective. What I tried to show was, even when you're giving the effective treatment, a lot of patients will have a poor outcome. And it doesn't mean your treatment hasn't worked. You can't see it at the individual patient level. Now, as we do more CT angiography and we see recanalization, we're starting to see that it is opening up arteries, which of course we couldn't in the early days. But I have very few absolute contraindications. I think the issues are, I mean, for microbleeds, for example, the literature would not suggest you need to be worried about microbleeds, and there may well be a surrogate for hypertension, which itself is a risk factor. So you don't need to do an MRI scan to look for microbleeds to make a decision around treating an older person. I think the difficulty is when you got people who've got a very poor prognosis because of the multiple problems they've got, and what the context of do you give thrombolysis to somebody who's got moderate dementia? And the answer is it's not really a medical decision. It's really a value-based one, and understanding what patients and their families would be their treatment preference. I mean, to give you an example, I'm now just over 60, but when I was 55, I said to my wife, under no circumstance do I want a hemicraniectomy if I have a major stroke. And that's my value judgment, that I don't want to. I'd rather die, have a high risk of dying and not being left disabled. But that, it's perfectly reasonable and appropriate to have a different view. And that, I think, is what makes stroke care both challenging and interesting, for people who are not straightforward. It's very easy to manage people in their 20s who have a stroke. You're going to do everything.
Interesting.
Thank you, Dr. Bruford. Last week I was on call, and they called me about one patient. She had almost the same as your patient. She had big left MCA stroke. She was aphasic, so she was the other side. She was bedridden. Her primary physician she's atrial fibrillation. There was risk of hemorrhage, so apixaban was withheld. Then she came with established right MCA stroke. So she was also a don't restate patient. So I was thinking, if she is in the window, will I treat or not? And I agree with you. Always go back to the family, speak to them. In our culture, they have expectation about living. They said, okay, if she's with us, we are okay. We'll prefer to treat her. So thank you very much for bringing a case that we will learn from.
Yeah, the only other comment I would make is I think there's a difference between thrombolysis, which is actually not very expensive if you have the infrastructure set up. The cost of the drug is very small compared to all the other costs of stroke care, and thrombectomy, which is a resource-intensive, expensive intervention, and certainly in the UK, it is not cost-effective for us to be using it in people with severe disability. But it is challenging because one always extends out of the trials to groups who weren't included for good reason as you get more experience. So I think it remains to be decided, the threshold for who should receive thrombectomy for large vessel occlusion. But again, there's no question about it will be beneficial in the groups. It's just you're going to see a higher mortality and more disability.
Dr. Mohammed, there's a questions to Dr. Eric, Prof. Smith. How about aggressive BP lowering and controlling hypertension patients? I'm speaking about blood pressure to be 120 or lower to control the cognitive and the vascular dementia. Is there any evidence for that? Those patients whose their blood pressure between 130, 140 compared to those who's around 120.
Yeah, the Sprint Mind study showed that the patients randomized the intensive control group, which was targeting systolic less than 120, had about 17% lower risk for MCI, dementia or a combined MCI and dementia endpoint. We want to call that evidence kind of moderate strength because it was a post hoc analysis. It was a secondary analysis. They needed to extend follow-up beyond the time when the trial was terminated early to accrue enough events. And although the hazard ratios for all these events were the same, as only when you combined MCI and dementia that you saw significance. So, but a meta regression of second analysis of multiple trials of blood pressure lowering, are consistent with that, though, right? That lowering blood pressure, and the more you lower blood pressure, the more you lower the risk for future cognitive decline. How low can you safely go? That is a question, and at least in Canada, notwithstanding the sprint results, the recommendations are still to aim for a systolic of less than 130. So among the hypertension experts in Canada, there was some concern about going that low. And although, they published that the safety and adverse event rate was low in the trial in SprintMind, I think when you extrapolate that to perhaps the more frail patients that are more typical of routine practice, there could be concern. They also measured blood pressure very precisely in SprintMind, and there's some evidence that blood pressure measurements in routine practice in the office may overestimate blood pressure compared to what they did in Sprint. So what they measured as 120 in Sprint based on multiple cycles of an automated blood pressure cuff after resting for 5 minutes would give you a more accurate lower blood pressure. If you measure the patients in the office, you might get like 135 instead of 120. Now you start giving them antihypertensives and you're driving their pressure down way too low, right? This is a concern because we don't have 5 minutes to spare just to let people sit and wait for their blood pressure. I mean, that's the reality of the practice, right? In stroke prevention clinic, is we got to get them in and out. So for those reasons, I think it proves the principle of controlling blood pressure is good, and the lower the better. But I think you do have to be mindful of potential adverse effects of blood pressure lowering in terms of the dizziness, orthostasis, and falls.
Dr. Mohammed.
Okay, thank you very much I think we are concluding here. Thank you for Prof. Ford and Prof. Smith for nice presentation, very important topics. We learned a lot as chairpersons, and I want to thank all participants who stayed late with us tonight. Other thing is very important, we didn't answer all the questions. We apologize for that because there are maybe 28. We just select most important questions. We apologize for any question was not answered. Thank you and have a good.
Yes, so Professor Ford and Professor Smith, so happy to see both of you tonight with us. Thanks for being with us from Calgary and UK, and hope to see you face to face soon in Dubai or Riyadh. Thank you.
Thank you.
Okay, bye-bye. Bye.